Recording in progress.
Good morning, everyone. Thank you for joining us for the Washington State Hospital Association Hospital Media Briefing. We are currently giving everyone recording privileges, and we'll get started in just a couple of moments. How are we looking, Liz?
Almost done with my parts. Need a few more seconds.
Okay, thanks.
All right. And Ashley, how are you doing?
Good on my end.
Okay, great.
And if I could just ask everyone to mute their lines if they're not currently talking, that'd be helpful for background noise. Thank you. This morning we have a great panel lined up for you. We'll start with the Washington State Hospital Association Executive Vice President, Taya Briley, who is a registered nurse and an attorney by trade. We also have Dr. Mary Fairchuck, who's the Medical Director of Pediatric Infectious Diseases at Mary Bridge Children's Hospital in Tacoma. Dr. Kevin Pieper, Chief Medical Officer of Cadillac Medical Center in the Tri-Cities. Dr. Karthikeyan Muthuswamy, an emergency department physician at Virginia Mason Franciscan Health. And Dr. John Haas, a pediatrician with Swedish Health. So thank you and welcome, and I'll turn it over to Taya for opening comments from the Hospital Association.
All right, thank you, Beth, and good morning, everybody. Thank you for your continued interest in how our healthcare system is doing. I wanted to start this morning by talking a little bit about COVID-19 case rates and hospitalizations. Our case rates and hospitalizations at this point seem to be hitting a plateau, and we don't like where we are plateauing. We saw a steady decrease in the number of COVID hospitalizations for the past several weeks, but the rate of decrease has been slowing. And the numbers are remaining flat in the past week compared to the prior one. There was an average of 1,007 confirmed hospitalizations for COVID this past week, compared to the prior week's average of 1,013. Of those that are in the hospital, an average of 177 COVID patients were on ventilators, which compares to an average of 187 on ventilators the prior week. This is a 5% decrease from last week. Hospital ICU capacity remains about 13% or 87% occupancy. Hospital acute care capacity remains at 11% or 89% occupancy. And hospitalized COVID deaths have varied over the weeks, but we are seeing an average of 12 to 15 deaths per day in the past week. And right now, COVID-19 hospitalizations are around 1,000 in Washington State on any given day, compared to 300 to 350 last June and July. And as a reminder, 1,000 hospitalizations per day was the peak of the surge that we had in December of 2020. And at that time, if you remember, we introduced significant additional mitigation measures to try and get the COVID-19 numbers under control. This year, the reins on social interactions are looser, which means that in addition to COVID-19, flu and RSV, another virus, are circulating in our community. and this is putting a lot of extra stress on our limited inpatient hospital capacity. One thing we don't know about a plateau is whether the cases are going to go up or down from here. And we need your help to do everything that we can to get those cases to go down. So please get vaccinated for COVID-19 and flu, mask, and follow social distancing recommendations. I want to talk about a trend that we are seeing in adolescent mental health this morning as well. One of the concerning trends that we've been seeing is an increase in the need for inpatient mental health treatment for adolescents. Reports from our pediatric facilities indicate the number of patients in need of treatment for mental health conditions like anxiety and depression have been higher overall in 2021 and has spiked significantly this fall, reflecting the return to school, resulting in identification of kids in need of treatment. Compared to this summer, the number of emergency department visits for adolescent anxiety and depression roughly doubled to 320 per week. This is an increase of 45% in the number of emergency department visits for those conditions compared to a year ago. And while the numbers are trending down a bit right now, we remain concerned about the overall high numbers. Because most of these kids in need of treatment are admitted through the emergency department, this puts additional pressure on the system overall. And this is especially true when we see pediatric emergency department visits for all types of conditions spiking. I want to also take a moment to celebrate the emergency use authorization for pediatric Pfizer vaccines. We'll be hearing a little bit more from our panelists about this, but this is great news. On Friday, the FDA issued an emergency use authorization for the pediatric Pfizer vaccine for 5 to 11-year-olds. Washington State has nearly 700,000 kids between 5 to 11 that are now eligible for vaccination. And the Washington State Department of Health has been preparing for a rollout. Supplies will likely be limited at first because of the difference between the pediatric formulation versus the adult. But that said, we believe that vaccination of this age group could begin as early as this week, and we urge those who are eligible to be vaccinated. It will protect not only these young kids, but all members of our community. And a reminder that immunization saves lives. And I want to take some time to share numbers with you that I found very impactful and significant. We saw from the Department of Health this week a report that shows unvaccinated 12 to 34-year-olds in Washington State are 5 times more likely to get COVID-19 compared to fully vaccinated 12 to 34-year-olds. They're 16 times more likely to be hospitalized. Unvaccinated 35 to 64-year-olds are 5 times more likely to get COVID-19 compared with those who are fully vaccinated, and 18 times more likely to be hospitalized. Unvaccinated individuals 65 years and older are 4 times more likely to get COVID-19, 9 times more likely to be hospitalized with COVID-19, and 9 times more likely to die of COVID-19 compared with those who are fully vaccinated that are 65 and older. So please, these numbers are really compelling, and we hope that they are motivating to encourage vaccination of everyone in our community who's eligible. I want to talk also about steps that we are taking to preserve our acute care capacity. Earlier in my report, you heard just how tight our acute care capacity is in this state. We have shared with you before that Washington is one of the states with the fewest inpatient beds per capita. We are to start what some in the trade call underbedded compared to most other states. If you add to this fact the crush of sick patients with COVID, flu, and patients who are extra sick because of delays in care that were due to COVID, bed capacity starts to get really thin. So there's a significant strain on inpatient beds from patients who no longer need acute care but can't leave the hospital because long-term care facilities cannot take them. We've talked some on these media briefings about that dynamic. And we've been working with the state and long-term care partners to encourage policy steps to increase long-term care capacity so that we can move patients out of acute care beds and into long-term care. We've had 2 good pieces of news that we want to share with you this week. First, the state is now opening COVID-positive skilled nursing facility units, and this will allow for a more rapid discharge of those patients who are COVID positive and can't go home but who also do not need acute care services. The second piece of good news is that the state is also extending long-term care payment incentives, which are crucial to providing the increased wages that we need to retain long-term care staff who can care for these non-acute patients. And so we're very happy that those incentives have been extended. And speaking of workforce, we want to talk with you also this morning about the work that we are doing to build the workforce for our acute care system as well. For all the reasons that we have shared, it is a really difficult time to be a healthcare worker. Many hospitals have adopted strategies to support our frontline staff, and we're very focused on retention of our existing staff. Many hospitals are providing retention bonuses, extra pay for working extra shifts, extra mental health benefits, more childcare benefits, and free food or cafeteria discounts during shifts. Despite this work to actively fill vacancies, many positions remain open. There are just not enough people to fill the staffing needs, and it is a national market. We are all competing for this same limited resource. But it is worth remembering that Washington State is a great place to work as a healthcare provider. We are currently ranked number 6 in the nation by Becker's Hospital Review for highest registered nurse salaries. And in fact, in California, which is ranked number 1 in the nation for nurse salaries, is also experiencing a nursing shortage. This really comes down to just not having enough individuals to fill these spaces. And while the nursing shortage is national and the worker shortage is national, we believe that many of the solutions are local. We are committed to working collaboratively on statewide long-term solutions to this problem, including advocating for more educational slots for nursing students and expansion of other allied health profession programs. We want to see increased pay for nursing instructors, and we'll work with our hospitals to ensure that we have expanded clinical placement opportunities so that we can get these folks trained up and ready to work in our hospitals. So with that, I am complete with my report here, and I'll turn it back over to Beth and our panelists to share more.
Thanks, Taya. We are going to now turn over to the pediatric view on things and celebration, as Taya mentioned, of the approval of the vaccine for kids 5 to 11. And we have 2 pediatric experts. So we're going to start today with Dr. Mary Fairchuck from Multicare.
Good morning. Thank you, everybody. So first, I'd like to share what our experience has been with Delta virus at Mary Bridge regarding pediatric patients. So we had our highest number of patients in the pediatric age group that we'd ever seen throughout the pandemic presenting for admission during September. That was the peak. We had 114 patients admitted during that time frame. October looks to be a bit better. We don't have final numbers yet, but we had gotten down to about 65 pediatric inpatients. Most of our kids that have been admitted actually fall in the under 2-year-old age group, but the majority of those who've been very sick and have had to go to the intensive care unit have actually been over age 10. And I don't think any of them have been vaccinated. So they're virtually all unvaccinated, even though they were vaccine eligible. We've also seen a dramatic increase in the number of children who are presenting with the post-COVID complication known as MIS-C, which is a severe complication in the wake of the infection. We've had about 45 approximate cases of that condition, and the vast majority of those children do end up in the intensive care unit and with cardiac issues related to that. Currently, we are concerned about the possible intersection of other respiratory viruses such as RSV and influenza if the coronavirus pandemic peak does not continue to subside. As was mentioned, we did not see that last winter due to all the mitigation measures that were in place. We really did not have a flu season or an RSV season, but we are already seeing RSV uptick in our community with many children admitted with that particular virus. We do know from previous experience that dual infections with respiratory viruses such as RSV can be much more severe than single infections. So that is definitely a concern. As was mentioned, we're very excited about the fact that the coronavirus vaccine does appear to be getting closer and closer to being able to get into children's arms with the approval last week with the FDA. Um, this is a very safe and effective vaccine, and we do know that at least 58% of children are still vulnerable to infection with this virus based on seroprevalence studies. And we know that in addition to the um, challenges that we see with pediatric infection, that they remain a source of infection to other vulnerable members of the community. So this is an encouraging note that we're hoping will be able to give us another tool to combat the coronavirus pandemic.
Thank you so much. And let's keep on the theme of pediatrics and what is happening in Seattle with Dr. John Haas from Swedish.
Hi, thank you for having me. I'm a pediatrician at the Swedish Pediatrics Clinic in West Seattle. Happy to join you guys to talk a little bit more about what we're seeing with COVID in children recently, and also talk a little bit about the good news regarding the vaccine in younger children. I do see some positive trends, I think, in the case rates in Washington State in the past couple of weeks. The daily rate is down to about 20 from a high of close to 50 during the peak of our Delta wave, though 20 is still pretty high, and it's as much as 3 times as high in some of the rural counties. Now, just looking at kids, we see similar trends in both teenagers and younger children, with the average daily rates decreasing compared to what they were during the peak of the Delta wave in September. And hopefully the hospitalization rate will kind of follow the downward trend in case rates as we've seen in previous waves of the pandemic. Kids still remain far less likely than adults to become severely ill or die from COVID. At one point, we were quite worried that with the Delta variant, that it would be not only more contagious, but also have significantly worse outcomes in children. But it looks like in terms of severity and mortality, the chance of a child who is infected having a bad outcome remains similar to our previous waves. Overall, the mortality in COVID has been about 1 death per 10,000 cases in children, and the hospitalization rate has been roughly 1 in 200 cases. I think the biggest difference I've seen in this wave of the pandemic has been in vaccinated versus unvaccinated teenagers, with a recent study showing that the hospitalization rate among unvaccinated teens was a full 10 times higher than vaccinated teenagers. As a pediatrician, I don't just deal with the physical health of children, but also their mental health. The toll of the social and physical isolation, the loss of family members, the uncertainty brought by the pandemic has been pretty significant for kids. In my own practice, I've seen a pretty stark increase in the visits for mental health problems for both middle school and high school age kids. And while access to mental health services has largely gone down during the pandemic, the rate of emergency room visits for mental health conditions has gone up. For instance, a study conducted during February and March of this year showed suicide attempts resulting in emergency room visits were about 50% higher in adolescent girls compared to the same period in 2019. But our next step in ending the pandemic is vaccinating children ages 5 to 11. And as you know, the FDA, based on a review of the evidence, has already determined that the benefits of the Pfizer vaccine outweigh its risks in this age group. We know it's safe and effective. Tomorrow, the CDC panel is meeting to decide whether the vaccine should be recommended for all children in this age group. And assuming they do, and that the CDC director agrees with their decision, we should see the vaccine start to become available to kids ages 5 to 11 sometime in the next few weeks. Now we'll be offering the vaccine at some of the Swedish clinics and also partnering with Amazon to offer it in the community. And you can find information about that on swedish.org, or also go to the Washington State vaccine locator to find a convenient vaccine site for your family. It's really imperative to get this group vaccinated as quickly as possible as we head into the respiratory illness and holiday season. These vaccines will make our schools safer, keep the kids in our community healthy, make it easier for the kids to stay in school and not to worry about quarantine. And we'll also keep those around them, both younger and older, safe as well. Some parents have questions about whether their child might be or can be vaccinated due to certain health conditions. In medicine, we would call a reason not to take a medicine or a vaccine a contraindication. And really the only contraindication to a COVID vaccine is a personal history of a severe allergic reaction to one of the vaccine's ingredients. And this is actually pretty rare. So almost everyone in this age group can be vaccinated. If you have any questions about this, you should reach out to your child's physician. From my perspective as a pediatrician in the community, I'm really excited about having COVID vaccine available to this younger age group, and I encourage parents to vaccinate their children as soon as possible, and I hope we all can enjoy a safe and vaccinated holiday season. Thank you.
Thank you. And I have a 9-year-old, and I can't wait to get her vaccinated. We're on all the waiting lists to find out when that will become available. I do have a follow-up question before we move on to our next panelist for both Dr. Fairchick and Dr. Pieper. Dr. Haas. I know that a lot of the concern with the vaccination, even for the 12 and above, was around the possibility for some cardiac issues. Dr. Fairchick, you mentioned in your comments the cardiac issues you were seeing in kids who have had COVID, who end up either with COVID or having the syndrome that potentially comes after that. Can you speak a little bit about the risks of cardiac issues for the vaccine versus actually having COVID?
Yes, before I get to that, I just want to make one clarification. When I was giving the numbers earlier, those were the numbers for our ER positives. So yes, there actually have been studies that have looked at that, what the risk is of the post-coronavirus vaccination myocarditis versus the risk of myocarditis or cardiac disease with the infection itself. The risk of the vaccine causing myocarditis has been really, when you pare it down, a risk that you see in young adult males. And that's what we've seen as well at Mary Bridge. The very rare cases we've seen have been in that age group. The statistics show that there's at least a 4 times higher risk of that very same age group having problems with their heart with acute coronavirus infection than due to the vaccine. So it's 4 times higher even in that highest risk group if they were to get the infection versus after the vaccination itself. And that doesn't even include the risks of the myocarditis due to the MIS-C, because MIS-C isn't really seen as often in that older age group. We see it most often actually in this new age group that now is eligible for the vaccine, the 4 to 11-year-olds. The median age for MIS-C is about age 9. So as far as if you're trying to look at that age group and the new recommendations for the vaccine, what are the risks of MIS-C causing carditis versus the risk of the vaccine causing a carditis? Right now it's a little bit hard to get those exact figures because no cases of myocarditis were actually seen at all in the vaccine trials in that age range. But that was expected because they didn't have, it's such a rare complication. You would have to have hundreds of thousands of children enrolled in the study to even see that. They did do some sort of scenarios when they looked at the data last week, projecting kind of worst case scenarios about what would happen if there was myocarditis associated with the vaccination in that age range versus what would happen with the infection itself. And essentially they again ruled that the risk of infection outweighed the risk of the vaccination. So hopefully that answers your question, but I think it does remain to be seen exactly what that rate will be.
Thank you. It does. I appreciate that. Anything to add, Dr. Haas?
No, I think that really covers it. I just think in the highest risk group for the myocarditis as a as a side effect from the vaccine, it's still the rate of cardiac complications from actual COVID is so much higher than in the vaccine that I think that what we've been seeing has been really positive as far as the safety of the vaccine goes.
Thank you. Let's head across the mountains and hear from Dr. Pieper from Cadillac Medical Center about what you're seeing in your community.
Hi, good morning. At Kedlock, we continue to see a high census of patients within our walls. We typically run around 250 inpatients or so. However, over the last couple of months, we've seen the percentage which are COVID decrease significantly. So we were running as high as 35% or so of our census being COVID patients in August. That number's come down to about 10% or so. However, that's plateaued over the last few weeks. Again, the majority of those are unvaccinated, like we saw earlier in this phase of the pandemic with Delta. As far as staffing, we're running still with a staffing shortage, just as everyone else across the nation. That hasn't changed a whole lot. We filled in with staffing, with travelers where we can, and extra shifts. I will say, since the vaccine mandate in mid-October, we're compliant with the mandate. We saw a very small percentage leave due to not wanting to comply with the mandate. But so that staffing shortage has been pretty consistent over the last several months, and not necessarily related to that.
Thank you very much. And then finally, let's hear from Dr. Muthuswamy.
Hey guys, thank you for having me here. I'm an ER doc down in Lakewood. My numbers represent about the same as what everybody else has said. About 10% of our beds are being taken up by COVID patients. That's about 133 patients in our system are COVID patients. The vast majority of which are unvaccinated patients. Every one of the patients in our ICU who's COVID positive is unvaccinated. You know, COVID admissions, 10% doesn't seem like a lot, but it actually affects our operations quite a bit because we have to make sure that those rooms are isolated. The amount of time it takes to take care of those patients are higher. We can't, some of these rooms are double rooms. We can't use them as double rooms anymore. Because of this, we are stretched to capacity. We have a lot of boarding patients, meaning patients who are sitting in the emergency department or sitting in hallway beds just because we are full. About 60 patients right now are boarding patients, and about 10% of those are ICU level patients. So COVID continues to take a toll, as everybody said. Even though the numbers are going down, it's plateauing at a relatively high number, much higher than what it was last year, and that continues to affect our operations. Fortunately, as far as the mandate goes, the vast majority of our employees complied with the mandate, have had religious or medical exemptions. So the issues that we've had with staffing existed well before the mandate. And that's just because there's just not enough staff. And this is a nationwide issue. There's just not enough staff to go around. And we continue to feel the pain from that. And we continue to feel the burnout from all of the hard work and the extra hours that we're putting in.
Thank you. Can you talk a little bit more about what you're seeing and how you yourself are coping with the stress that has been ongoing? I think we had you on probably about a year ago. And how have things changed for you and your team, and how are you taking care of each other?
It's hard. You know, I remember when I was here last year, I was very excited that more people are going to get the vaccine. We're going to squish this. This is not going to be a thing in 2021. And then 2021 just says, here, hold my beer. I was supposed to go on 2 vacations that we had to cancel just because, you know, everybody needs help and we have to help each other. Historically, and of course, this is all anecdotal data, whenever I have to code a young patient, it's almost always due to trauma. In the last year and a half, if I'm coding a young patient, I can pretty much guarantee it was an unvaccinated COVID patient, and that's borne out. Again, it's anecdotal data, of course. A week and a half ago, I had to code 2 40-year-old patients who did not survive. They were unvaccinated COVID patients. There was a mid-30s patient who also needed critical care. I'm not sure he'll survive much longer. He did survive the initial resuscitation events. That wears on you. You know, taking care of any sick patient is not easy. But when you see it in younger and younger patients, it really, really hurts your soul in a way that's very difficult to describe. And I've been doing this 10 years, and I've had to take care of critical young patients more in the last year and a half than I've done in 10 years of doing this. And that's difficult for everybody. And you know what? There's a famous saying from a show that I like, Scrubs, where the doctor says, you know, that family in that room, their life has changed. They're not going back to work. They're not going back to work for the next week. I have 20 patients in my waiting room and I have to come back to work the next day. That's hard. What makes this better is that my staff is awesome. We've all been through this. We've all been through the pain and we support each other. Our administration supports us. It's a hard time. There's no free pizza that's going to make this better, but it's nice to know that you are there with people who understand what you're going through, that have your back, that help you through this. And that's what helped us. And all I can ask is the general public, please help us. We're helping you as much as we can. Help us by getting vaccinated. It's the best thing you can do to save yourself and save me a lot of heartache too.
Thank you. It's powerful. Do other folks have comments they'd like to make on their own experience of this ongoing pandemic and what you're seeing with your teams?
I would like to echo what was just said, that I don't think that the soundbite, although it may be appealing, should be there's staff shortages due to vaccine mandates. I think in addition to the workforce issues, there are also staff shortages due to burnout. And it's been very difficult for healthcare providers who are dealing with this pandemic to feel like we have two battlefronts. We have the battlefront in the hospital and the clinic every day, and we have the battlefront of misinformation, which has been very, very difficult to feel like we can't even just engage with trying to fight this deadly virus. We also have to engage with all of the misinformation out there that is sabotaging us.
Thank you.
Yeah, and I think to echo what the other two said, I mean, compassion fatigue is real, and there's a lot of frustration of our caregivers. They're tired, they're exhausted, they've been taking extra shifts and taking care of a lot of patients that it really feels like could have been avoidable admissions if vaccines were accepted at a higher rate. I think even more frustrating is the care that we've had to delay. So it's uncomfortable for all of us to think about patients such as a cancer patient, for instance, who had to have their care delayed due to something that felt avoidable. And the list goes on of diagnoses where it would have been much better to get them in the OR or in for treatment that we haven't been able to do due to the high volumes of COVID that we've taken care of.
Thank you. We do have a few questions in the chat. We are going to go ahead and open it up to questions. So if you have questions, please do put them in the chat, or you are welcome to unmute yourselves and ask them. I'm just going to go up to the top here. And I believe Dr. Muthuswamy did put an answer in here, but there was a question about when someone decides they want to enter nursing, how long from their start does it take them to actually get on the job? And Dr. Muthuswamy did put an answer in the chat. I'm wondering if others have comments they'd like to make verbally on that.
Beth, this is Taya, and one thing I would just add, having been through nursing training myself, is that partway through nursing training, one can work as a nursing technician, and that does put a person right at the bedside during nursing training that actually can provide quite a bit of care. And that's possible after just 1 year of nursing school for a registered nurse. I'm not sure how it works for all the other nurse training programs, but that is a really powerful tool, and one that I know a number of hospitals have been looking to leverage, is the nursing technician role.
And I would note too, we have a number of folks on that are from broadcast media, both television and radio. So it might be helpful if we could voice Dr. Muthuswamy, if you want to say what you said about nurse training, that would be helpful too for those folks.
Oh, I apologize. I just didn't want to interrupt the group. So there's lots of different levels of nursing training. Again, I caveat this by I'm a doctor. I work with nurses all my life, but still doctor, so I don't have the firsthand experience. The easiest level of training, by which I mean the shortest training, is for the most part a licensed practical nurse, which is not the same thing as a full registered nurse. There are limitations in what they can do. That's about 2 years of training. Some hospitals will accept an associate's degree to become a nurse, but most of them encourage a bachelor's degree for a registered nurse. That's about 4 years. And on top of that, there are always higher level graduate training that you can do as well. Certain areas, such as ICUs, some ERs, trauma areas, do want you to do more on the job training after you get there. So although you are a registered nurse, you're kind of flying under the wing of a more senior nurse for up to a year. So it varies anywhere from 2 years of training to 4+ years of training from the moment you want to become a nurse. Of course, that doesn't take into account the time it takes to apply, to get in, to get your prerequisites and things like that.
Thank you. And I should also note that our staffing shortages are kind of across the board too. While nurses are certainly the backbone and a very important part of the team, I think we have shortages in respiratory therapists, other technicians, and technologists. We have shortages among physicians. So there are a number of areas, and the support staff as well. So there are a number of areas where we can use more highly trained folks to help make hospitals and the healthcare system run well. And also wanted to note too, this was something that we are seeing that is changing in the nursing workforce. It's similar to what we saw with the physician workforce, in that people are now wanting to work different kinds of schedules. They want to maybe work part-time or not a full-time job. And so a nurse graduate that may previously, 20 years ago, have filled a full-time position, we may need more than one person to fill that need now. So the workforce is certainly changing in healthcare and across all industries. Let's go to the next question. How much of an issue is patient boarding in hospitals across the state right now, and how much does it compare to past levels of boarding? Can you also please explain what it's like for a patient to be in that situation? Taya, do you want to take a run at this one?
Yeah, I'm happy to. And I would also encourage our panelists to give their perspective. So what I can say right now, without being able to offer numbers at my fingertips, is that the situation of boarding in our state is significant, and it is worse than it has been in prior years. The challenge of getting patients discharged out of the hospital so that patients can come into the hospital for acute care is one that we have been working on for years, literally, but the COVID pandemic has exacerbated it significantly. Long-term care facilities are challenged to take COVID positive patients, even ones that are in the process of recovering because of the risk of transmission to other patients in the facilities. They are often a place that patients go once they don't need acute care, but need some sort of care after their acute care experience. Also, staffing shortages in long-term care facilities are also making it difficult to move patients out. So all of that translates into patients who can't get in, and this experience of boarding in the emergency department that has been described. And this boarding experience, it can be an experience for pediatric adolescent patients. It can be an experience for our elderly patients as well. It is across the board happening in our emergency rooms. And I want to turn it over to our panelists to talk about what this is like for patients. It is not a positive experience, I think it's safe to say, but I would turn to them to explain what those particular dynamics are like.
I've got lots of anecdotal stories of this as well. Last week, I had an 80-year-old patient who had fallen and broken her hip. Very painful, can't really move. The good news is that she didn't need critical level care. The bad news is that means you could move to the hallway. So imagine this is your grandmother with a broken hip, in pain, in the hallway, and she can see people passing by. She can see ambulances passing by. This is, of course, at 2 a.m. So she can't get any sleep either. she's still getting excellent care from the perspective of we're making sure that she's comfortable. We're making sure that she's not getting a blood clot. We're making sure that she's not getting any hospital-acquired infections. We're making sure of all of that. But I wouldn't feel that great if it was my grandmother with a broken hip that's in the hallway. It's unfortunate that that is the situation that we're in. And as they mentioned, this is not new, unfortunately. Temporary bed locations, hallway bed locations for admitted patients is not a new thing in hospital medicine. It's definitely been exacerbated by the COVID pandemic because of what I said before. We have double, triple rooms that we can't use as double, triple rooms if there's a COVID patient that's in there. So it's artificially reduced the number of spaces that we have. So we have to use all these locations. And it's frustrating on all sides. The patient, the caretakers, everybody is frustrated. I wish we have a better solution. The solution is to not provide care. Obviously, we want to make sure we take care of them. So we do the best we can.
And Dr. Pieper, do you have any patients right now that have been long-term waiting for discharge that are just kind of stuck in the hospital? I think that's also where we see the backup then that ends up in that overflow in the ER.
Yeah, we do. And that number varies. Eventually we get some placed, but it bottlenecks the whole system. So we end up with patients in the ICU that don't need ICU care anymore because they can't get an acute care bed. And that backs up into the ED, and we end up with patients who are boarding, meaning less rooms for our ED physicians to see patients, full waiting rooms, and eventually patients leaving without being seen. And I don't think we really have a measurable way of knowing the effects, but we can all surmise that once you delay that care, and those patients are going to be less likely to come back because they're frustrated and angry, that their outcomes are going to be poorer as well.
Thank you. It's certainly something that we will continue to work on and hopefully be able to move patients to the appropriate level of care so that it frees up the system. Appreciate your comments and thoughts there. Let's go to the next questions we have now are really about the vaccination. We have 3 of them. The first is, do we have a day where we expect shots to actually be available? The second is, how important is it that kids get vaccinated quickly? And then the third is, to what extent do you expect parents' hesitancy to play a role in youth vaccinations 5 to 11? And are pediatricians prepping for those conversations? So I will turn it over to our pediatric experts to take runs at those answers.
Well, as far as when it will be available, this week the ACIP and the CDC will be meeting to determine exactly what to recommend in terms of who should receive the vaccine. Once that's done, as has already been mentioned, the state is poised to be able to have doses to deliver, and we will be able to deliver them throughout the state. Multi-care will have them available in our clinics and pharmacies, as well as for our inpatients. I think the second question, very importantly, is how vital is it to get this vaccination into the arms of children? And I think it's vitally important. I think it's the most effective weapon that we've had against this virus. And although it may be tempting to dismiss the idea of vaccinating the 4 to 11-year-old age group because they are the group at lowest risk for things like hospitalization and death, we shouldn't be minimizing that, what the effect of the virus is on this age group. It was still the 6th leading cause of death in 4 to 11-year-olds during Delta, which is, kids of this age are not supposed to die. So they still are dying of coronavirus. They still are being hospitalized. We still have the problems with the MISC. Around 7 to 8% of them are experiencing long COVID, which means symptoms that go on for more than 12 weeks at a time. And even beyond that, it's just, this is a very wily virus. As long as there's tinder for the fire, meaning unvaccinated individuals that can get infected, we're not going to get on top of it. And if we're refusing to use a very effective weapon against it, it's like trying to fight the virus with one hand tied behind our backs. And why would we want to do that? I shudder to think about what Delta would have been like had we not had the vaccination. As we've been saying over and over and over again, the vast majority of patients who've been unfortunately hospitalized and have died during Delta have been those who were unvaccinated. Just try to picture what would have happened had Delta surged prior to having the vaccination. We already reached the peak levels that we had in December when we didn't have that tool. So I just think that we need to really emphasize how safe and effective this vaccine is and what an important tool it is so that we can all get over this and the children can get over school closures and the mental health issues that they're battling due to this, as well as the very real health issues that they're experiencing.
Thank you. Dr.
Yeah,
Hawk.
I definitely agree with everything that you just said there. I think, the COVID vaccine or a COVID vaccine has been given to 7 billion people worldwide, 500 million people in the United States, 500 million doses. It's been tested on several thousand kids, in this age group, and there hasn't been a single serious side effect in the children age 5 to 11 who've received the vaccine so far. So I think we know it's safe and effective. I think we're all familiar with a lot of tragic cases of when vaccines were available to adults and people hesitated and they got very sick or died while they were still trying to wait and see. And I don't want us to do that with children. I think that the flu season, respiratory season is upon us. We're getting ready to. Some people will be traveling for holidays. People want to see their families and friends for Thanksgiving, Christmas. So I think it's really important that people get vaccinated, children get vaccinated as soon as possible. I think once we have these vaccines rolled out in the coming weeks, we'll have vaccines available essentially from kindergarten through high school. So I think it can also change the way that schools approach exposures. For instance, it might change the quarantine requirements if you have a close contact. So that can help keep kids, even who don't have COVID but who've maybe been exposed. It can help keep them in school. So I think there are a lot of reasons to get the vaccine as soon as possible.
And are you already having these kinds of conversations with parents in preparation, or what are you anticipating in the coming weeks?
Yeah. Every checkup I've done with a kid in this age group in the past couple months, I mentioned, the vaccine will probably be coming out pretty soon, and is that something you think you're going to do? And I get a lot of questions. I've had a lot of positive responses personally, and most of the parents say yes, they are. The questions they have are very similar to the questions around that they have for their teenagers. And similar to questions, regarding the safety and efficacy for adults as well. I think it's really important how we talk about vaccines. I like to talk about vaccines and the COVID vaccine as a way that your body is trained to fight a virus that it hasn't seen before. So when you get the COVID vaccine, it's training your immune system. It's helping you to produce antibodies, so that when your body encounters the real thing, it's already prepared to fight against it. So and I think that all pediatricians were experienced talking with parents who have questions about vaccines. So I think that they'll be once these are rolled out in the coming weeks, I think pediatricians will be prepared to talk about it with their parents.
Thank you. We do have a question. Obviously, the 5 to 11 vaccine that is coming up for final approval is the Pfizer vaccine. There's a question about, do you have any more details about the delay for further review of the Moderna vaccine for kids? And did that, there was a question about whether that myocarditis was part of that.
Yes, I think they're referring to the delay for review of the application to extend the Moderna down to age 12, as it has been for Pfizer prior to this newest approval. And yes, it is so the CDC can, or the FDA can further evaluate risks for myocarditis with that vaccine. Certain countries, I believe Norway and Sweden, I think, have put a halt to that for younger age groups due to that concern. So I think that this is actually something that we should all be very encouraged by, because it shows us that we need to trust the process, that the FDA is being very wise about weighing risks and benefits before approving anything to be launched into the arms of children. And so I think that we should be very happy that they're taking their time to look at that.
Thank you. Another question is, can you share some recommendations for gatherings, et cetera, as we approach Thanksgiving and other holidays in the context of plateauing cases and hospitalizations? I think we're plateaued much higher than we were before the summer surge started. Last time we had a plateau for several weeks for about 300 hospitalizations. That's significantly different. So any thoughts on gathering for the holidays this year?
Yeah, when parents ask me about that, I say that I think that everyone who is eligible to be vaccinated should be vaccinated. And no one with any symptoms should be attending gatherings. And I think if you're having a small gathering of 4 or 6 people, that's probably sufficient. If you're thinking of having a larger gathering of 12 people, which there might be reasons to be hesitant about that. But if that is something you're thinking of doing, that's a good use for the rapid test if you're getting a larger group together like that, to just have everyone do a rapid test before coming.
And I would echo those recommendations. I would love to go for Christmas dinner, but I will be working Christmas. But it's hard. You need a sense of normalcy. You need a sense of gathering. We're doing all of this. We're all getting the vaccine to do the right thing, not just for yourself, but for everybody else around you. So it's fair to be okay with the small gatherings, like you said. It's just the larger your gathering gets, the risk kind of goes up, not just linearly, but somewhat exponentially. So then the rapid test would be more helpful. It's so hard for me to tell people 2 years in a row, don't go see your family for Christmas and Thanksgiving, because I have older parents and I'd like to see them. So just please be careful, take the right precautions, and keep the gatherings as small as possible is all I can say.
Yeah, the only thing I would add to that is let's not forget about the high-risk family members getting their booster if they're already vaccinated, as well as everyone getting the influenza vaccine. I don't think we should ignore influenza at all.
Thank you. Good point. And also, I think that some of the public health recommendations from last year would probably hold true of well-ventilated spaces, some distancing, still masking, that kind of thing. So thank you very much for those insights. We do have a couple of additional questions. Tay, I don't know if we have an answer to this one. Does WSHA have any more details about the COVID long-term care sites, how many there are and how long they will be in operation? I know we have some here in Spokane, but how widespread are the sites?
Yeah, so I'm going to go ahead and turn it over to Zosha Stanley on our staff, who has become the expert on this topic. Zosha, you ready to go?
Yeah, can you guys hear me okay?
Yes, thank you.
Okay. Yeah, we got updates from DSHS late last week that there will be 5 facilities, COVID positive SNF units. Those facilities will have a capacity of 100 beds in Western Washington and 10 in Eastern Washington. And I could put in the chat, there is actually a DSHS website that lists the sites for those COVID positive facilities. So we'll put that in the chat.
Thanks so
and
much.
I believe, yeah, and sorry, the other details, I believe that they are funded through the end of the year. And I believe they're coming online, I think early November, so nowish.
Thanks, and we can hook you up with a person from DSHS too if you'd like more details on that. Thank you, Zosha. And then we do not yet have exact data or percentages, but what are we hearing from hospitals having to curtail services in light of the vaccine mandate? The impact of the vaccine requirement going into effect, really, there has been some impact, but it's been much lower than what we all feared that it could be. And so we are having some impact on services where people are continuing to see delays in care. And we've had a couple of hospitals that had to curtail a service or two, and they've been working on getting those patients care elsewhere. Taya, do you have anything else to add to that?
No, I think that's a really good way to summarize it. We've been managing much better than we thought we might, and where there are limitations in services, it's more like folks can't take as many patients as they might be able to, might have been able to, but they aren't having to shutter services altogether. And as Beth said, where there have been those isolated instances where services can't be offered, folks are finding ways to be able to refer those patients.
Thank you. And we are going to be collecting more data from our hospitals on this with impact as they have worked through folks that had to still give their proof of vaccination at the time of the deadline, and folks that were partially vaccinated and those kind of things. So we were giving them a couple of weeks to work through all of that processing before we asked them again about impacts. Another question, Kate Walters asked, do we have a guess on actual timeline for if that approval happens tomorrow for the kids' vaccines? When would folks anticipate that they would be starting to give vaccinations? I think we sort of answered this, but maybe do you have a guess on it? Is it this week or next week kind of thing?
So my understanding is that they're pushing for the approval to happen this week. My wife is a pharmacist, and she says that their pharmacy is going to be ready to go as soon as the approval comes through. The only difference is there's a slight logistical difference because the actual vial that's used for the vaccine for kids for 5 to 11 is, I believe, a little bit different than the one that's used for adults. So that may cause a day or two for them to kind of figure out their system. But my understanding is it's going to happen very quickly. It's going to be available within days of all the approvals go through.
And I would just add that the Washington State Department of Health is the ultimate authority on when the trigger gets pulled here in our state. There has been an additional step that Washington has taken in terms of review with a Western State Pact of states that has done a review in addition to the federal review. So the State Department of Health will be able to give you the update on exactly the timing of that review and when they'll be ready to release the vaccine here in our state.
Thank you. And we have one more question that I see in the chat box that we haven't answered. Are Washington hospitals still taking significant numbers of patients from Idaho? Does the Idaho situation appear to be getting better? Taya, do you have a sense of that?
Yeah, so Washington hospitals are absolutely continuing to take patients from Idaho. It is a part of our normal transfer pattern to do so. And some Washington patients may at some points be transferred their direction as well. I think the big thing that we have seen is that we've come down off of the peak of our most recent surge. And so the pressure has lessened. However, I do worry about the fact that we are seeming to plateau at a level that is as high as it is. And if the numbers ramp back up, particularly given the low vaccination rate in Idaho, that may increase the pressure again on Washington hospitals. So I would turn to any of the other panels if they have more to add, but that's sort of my thinking from a statewide perspective.
Thank you. And thank you all to all the panelists for joining us today. We are right at about time. We really appreciate your taking the time today. Thank you to the members of the media for attending and continuing to get the information out to the public so that we can really make an impact on this disease. I think as you heard everyone say, please do get your child vaccinated if they're in that 5 to 11 age group, and get your flu shots so that we don't have increased hospitalizations for respiratory illness this year. So thank you all and have a safe week, and we'll be back in 2 weeks.